Okay, our next speaker is the Chief of Staff of the White House Office of Drug Control, the National Drug Control Policy. You'll hear Frank and some of the others of us refer to these things as the anachronisms or the abbreviations. And we'll try to guard against that for those of you who don't know what HIDA and ONDCP is and things of that nature. We'll try to spell those out. She manages the day-to-day operations of the White House Office of National Drug Control Policy and assists the director of that in implementing the administration's national drug control strategy. She is the primary architect of the prescription drug prevention strategy issued by ONDCP in April of 2011. She has served for 8 years as the legal counsel to the mayor of Seattle, Washington. In that regard, she was in charge of public safety, criminal justice, and legal policy issues. She's worked in numerous political and policy positions in local, state, and federal government, and has practiced law in Seattle. She is an adjunct professor at Seattle University Institute for Policy Studies, where she has taught ethics and legislative policy making. She is a magna cum laude graduate of Boston College and received her law degree from Georgetown Law School. Welcome, if you would, Patty LaBelle. Regina LaBelle, sorry. You're not going to sing, right? Regina LaBelle, not Patty, right?
Okay, I don't sing.
You're not going to sing? Thank you.
Thank you very much. I wish I could say that was the first time that's happened, but it just happened last week, so it's okay. Good morning, and thank you so much for inviting me today, and for, most importantly, to the Appalachia HIDA for organizing this conference and the U.S. attorneys coming together. As was said, this is something that we have been working on since my boss, Gil Kurlikowski, came in and was appointed to be the head of Office of National Drug Control Policy in 2009. And he said this many times, and I apologize if you've heard it, but I think it bears repeating. He had been the police chief in the Seattle Police Department for 9 years, and came to Washington, D.C., and when they were prepping him for his hearings before the Senate Judiciary Committee, they said, well, you know that more people die from prescription drug overdoses than die in car accidents, right? And he said, no, I didn't know that. So he asked some of his colleagues around the country in law enforcement, and they were not aware of it either. I think that we have at least recognized, we have more recognition in this country of the problems of prescription drug abuse than we have in the past. That actually is at least one good step. We have had summits such as this around the country. We've been doing these now for about 3 years. We really have, I want to talk this morning about the prescription drug abuse plan that was issued in 2010 in April, and we have been working across the country on state and local efforts that emulate that plan. And I want to talk a little bit about some of the trends and some bright spots, some not so bright spots, and why I think summits such as this can really help bring the issue under control and bend the curve on one of the biggest consequences, which is drug overdose deaths, as well as in new initiates, people using prescription drugs for the first time. So thank you again, and to all the U.S. attorneys who are here in the Appalachia HIDA for bringing us to today. Okay. So we have a national drug control strategy that we are in charge of issuing for the president every year. And the National Drug Control Strategy is our primary blueprint for drug policy in the United States. The strategy reviews the progress we've made. It establishes specific goals over a 5-year period over every aspect of drug use in the country, drug use and its consequences. The strategy is guided by 3 important facts: that addiction is a brain disease that can be treated, people with substance use disorders can recover, and innovative new criminal justice reforms can stop the revolving door of drug use, crime, incarceration, and rearrest. We issued this in May of this year. We are now beginning to take input into our next strategy, which we will issue next year. But again, it builds on those simple premises about drug use and its consequences in the country. The U.S. prescription drug abuse problem in this country is not, while it is very acute in this part of the country, it is not limited to this part of the country. It exists across the nation. In Washington State, where I lived for 16 years, it was very significant. But again, the policymakers, I worked for the mayor, we were not aware of the extent of this problem. 6.8 million Americans reported current non-medical use of prescription drugs in 2012. That's the latest data that's the latest source of data. 1 in 4 people using drugs for the first time in 2012 began by using a prescription drug non-medically. Of the 38,000 or so drug overdose deaths in 2010, that's the latest data that we have is the 2010 data, approximately 22,000 involved prescription drugs. And 16,000 involved opioids, so OxyContin, hydrocodone, etc. This has human costs that are incredibly significant in many parts of the country. It also has other costs, other societal costs, $25 billion in direct health care costs, and $5.1 billion in criminal justice costs. Studies have found that individuals abusing opioids generate on average annual health care costs 8.7 times higher than non-abusers. This chart shows the death rate trends in our country. Again, this goes back to what I was saying about motor vehicle traffic. We have safer cars. People use seat belts. We have lots more safety equipment in cars now. Motor vehicle traffic deaths have gone down. Poisonings and drug poisoning, overdose deaths, so you see where that has crossed now, where that is the only indicator, and the Centers for Disease Control and Prevention, with whom we work quite closely, has indicated this is one of the only areas of accidental deaths and accidental injuries that is on the rise. It's prescription drug overdose deaths. This shows where the overdose death rates are highest. And we have the Appalachia region, the Northwest, the Southwest, a very big problem there, the Appalachia region, and Florida. The 2010 data, we are very anxious to get the new data. I am afraid it's going to go up before it goes down, because if we didn't start kind of working together in a holistic way on this until 2011, we have a lot of people who started using drugs, using prescription drugs, abusing prescription drugs, and so their chronic rates of use has gone up, which means that their overdose death rates will go up for hopefully only 1 or 2 more years, and then we'll start bending the curve. Overdose death rates for specific drugs, and we say this all the time, and this is, it's, you know, we have focused a lot in this country on heroin and cocaine. Those death rates are down. Twice as many people die from prescription drug overdoses as die from heroin and cocaine combined. So we have the shocking statistics that you are all too familiar with in your own communities of death rates and overdose death rates and abuse and misuse. One thing that we did, we asked HHS, when they give us this data on who's abusing drugs, who's misusing prescription drugs, it's very important to look at the source of the prescription drugs. Where are people getting these? And it changes from initial misuse to chronic use and chronic abuse. If for substance use disorders, it's a progressive disease. So if you start misusing prescription drugs, where over 70% of all people who misuse or abuse prescription drugs get them from family and friends. They're not buying them from drug dealers. That's what makes this a very unique issue. They get them from family and friends. So the recent initiates, people who have just begun misusing or abusing prescription drugs, are still much more likely to have gotten them from a family or friend for free. Prescribed from one or more doctors, doctor shopping, it's, it's about, about 17%. That stays, the doctor shopping stays about the same until you get to the chronic users, people who have a chronic substance use disorder. 26% are more likely to doctor shop. And then it falls down about 20%. Doctor shopping is, you have to go buy your drugs if you have a chronic problem. You have to doctor shop if you have a chronic problem. You're less likely to be able to sustain your addiction by getting them from family or friends. We have spent almost all of our time focusing on the chronic user, because that's where it costs. We see it in society. You see it as law enforcement professionals. Healthcare professionals have people with chronic addictions showing up at their doorstep. What we are trying to do, and why our plan is called a prevention plan, is focus on the beginning, is focus on that original. There are far too many prescription drugs that are being left in homes, far too many prescription drugs that are being prescribed. And so that's where we need to stop that and shut it off at the beginning. It doesn't mean that we don't need to focus on the chronic user, but it does mean that we have to look at it across the spectrum. This is a very important piece of the plan. So as we gather all this information, and as was said, I'm a lawyer, but I know my limits on practicing medicine. So we had a PhD pharmacist and a neuroscientist who worked very closely with us on this, on developing the plan, as well as the entirety of all the federal agencies and the expertise that's available in the federal government to work on this plan. We looked at where are the prescription drugs coming from, who's misusing, who's abusing them, who's dying from them. And we developed this plan that has 4 pillars. The first is education. I'm going to go into it in a little more detail, but the first piece of education is educating parents about the dangers of prescription drugs, because we found that parents thought, and young people thought, if it was prescribed by a doctor, it must be safe. So if I want to misuse those prescription drugs, it's not as dangerous. So it's very important that we get parents to understand how dangerous prescription drugs can be if abused. It's also important to educate doctors about prescribing practices and alternatives to using only opioids, to prescribing long-term opioids. The second is prescription drug monitoring programs. All of your states have very good programs. They are in place now. They are improving in many places. I know Kentucky's done a great deal of work, as well as the other states, to make the prescription drug monitoring programs more effective. Third, proper medication disposal. Getting rid of those prescription drugs that start the problem from the beginning. And then enforcement. And enforcement of making sure that we have laws against doctor shopping in certain cases, making sure that we are cracking down on the pill mills that were rampant in Florida and across the Southeast. So I want to talk about education a bit. Education of prescribers and training of prescribers, as I mentioned, is very important. It has been somewhat of a challenge, however, because we have many the medical community obviously is very well trained and are experts in their field. So it is difficult to tell them you may not be prescribing correctly and you may not have enough education in this area. So we have worked very closely with the pharmacists, with nurses, with anesthesiologists and dentists and many other specialty groups across the country to make available more prescription drug training. Unfortunately, the training in opioid prescribing had come primarily from the pharmaceutical industry for a number of years. And so we really need to make a change in that it's coming from the specialty societies. So the Department of Health and Human Services is expanding training for prescribers working in their agencies, making it mandatory for them. The Bureau of Prisons will also make prescriber education mandatory. We don't have a mandatory training program in place for non-federal employees who are prescribers, but we are working with those specialty societies. That would have to be something that's passed by Congress, and I don't know if you've noticed lately, but Congress isn't doing a lot of that type of work. So we are encouraging, cajoling, working with our local groups to make sure that, that their prescribers are educated in a neutral fashion about how to treat pain and about substance use disorders generally. The Food and Drug Administration put forward its REMS program, which is an education program that they have a goal of training prescribers around the country, and it's actually going well. It's not mandatory, but it is reaching a lot of people who otherwise would not be educated about proper opioid prescribing. And then on the other education piece, which is the prevention piece, we work very closely with the partnership at drugfree.org to get the word out to parents excuse me, and patients about the dangers of misusing prescription drugs and about proper disposal as well. So monitoring. Prescription drug monitoring programs are just one piece. We tend sometimes to look at it as the prescription drug monitoring program as the one thing that's going to solve this problem. There is not one thing. There are many pieces of this puzzle. When I started at ONDCP, we had about 25 states, 24, 25 states that had prescription drug monitoring programs. In the last 2 years, there's been a rapid expansion of prescription drug monitoring programs around the country. There's only Missouri and DC that do not have prescription drug monitoring programs currently in place. And just having this tool is not enough. We need to make sure that people use them. I know that Kentucky has a mandate now for prescribers to check the PDMP before they prescribe. We also have to make it so that if we're going to make it mandatory, it's got to be a good tool. It has to be something that's not complicated and difficult and have a lot of barriers for use. So we're working with it's called the National Coordinator for Health IT at Health and Human Services to have pilot programs around the country to make these PDMPs, the prescription drug monitoring programs, work better. The prescription drug monitoring program is basically just a database for all prescriptions that are prescribed to an individual. So if you are a prescriber, and we see it as an early warning system, if you're a dentist and you want to prescribe Vicodin to someone, it's probably important for you to check the PDMP before you prescribe, because that individual may have gone to 5 other dentists to have the same root canal or a similar root canal. We have heard from individuals who had substance use disorders that they voluntarily underwent root canals, which is frightening to me. They voluntarily underwent root canals just to obtain the Vicodin. And that's something that the prescription drug monitoring program, if you've got someone who's had 4 different scripts for Vicodin the last 5 weeks or 2 months, there might be a sign that there's a problem there. So that's what the prescription drug monitoring program does primarily. It is an early warning tool. It can alert prescribers to a potential substance use disorder. That individual can then intervene with the individual and say, I'm not going to prescribe this to you. Here are some treatment centers. I'm not going to prescribe this to you, period. There are many choices down the road, and a lot of states are doing a lot of work to make sure that that work, the prescription drug monitoring program, isn't just a database, that it allows for a dialogue between the patient and the doctor about that person's disease. So, I'm sorry, this is the map with Missouri in the middle, without PDMP. It's been a very a very divisive discussion in Missouri about why not to have a PDMP. There's one individual in particular who's the chair of a committee who filibustered and kept it from coming to the floor last year, and we anticipate it'll be another battle again next year. Our HIDA in the area has been very engaged in trying to get the PDMP in place. It may take them getting more pill mills operating in Missouri before they take action, unfortunately, but it's been a very divisive debate. So proper medication disposal. When in 2010, the President signed into law the Safe and Responsible Drug Disposal Act. DEA is working on the rules for that law so that communities, local groups can take prescription drugs back because of the closed system of our Controlled Substances Act. They were unable, you couldn't have just community groups doing prescription drug takebacks. That's why the takebacks that we have, and there's another one coming up in October, the takebacks that we have to be run by either the DEA or local law enforcement. And DEA has been phenomenal in conducting these every 6 months, these takebacks every 6 months. And they have safely disposed of tons of prescription drugs around the country. And I've been to many of them, and people, particularly elderly people, show up with just a big bag of prescription drugs that they had in their home. And now we know that they'll be safely taken out of their home so they can't be diverted. The drug disposal regs should be done early next year. We were hoping by the end of this year, but we're told probably early next year. And then local community groups will be able then to conduct these takebacks on their own, and you won't have to have DEA conducting them themselves. So enforcement. Enforcement is the fourth and final pillar of the Prescription Drug Prevention Plan. HIDAs have been very engaged in this work. We also have another funded program from the HIDAs is the National Methamphetamine and Pharmaceutical Initiative. They conduct training for law enforcement on pill mills, on how to build a pill case. And they've done training around the country to thousands of law enforcement and prosecutors on prescription drug diversion cases. We also have been very pleased with the work of the Drug Enforcement Administration and the U.S. attorneys in Florida, Georgia, and many other states in getting rid of the pill mills. The number of prescription drugs in Florida that had been prescribed was off the charts during the era of the pill mill, and they have come down significantly since then. We're now left with the consequences of that because we have, of the pill mills, because we have many more people who have substance use disorders, we have many more drug overdoses, we have babies being born with neonatal abstinence syndrome, which means their mother had an addiction to prescription drugs. So we're now kind of cleaning up after that, but at least the pill mills are not in operation, and that's thanks to the efforts of the U.S. Attorney's Office and DEA in that area. So I want to turn to a couple emerging issues on prescription drugs and prescription opioids and heroin. I don't know if you're going to talk about that at all. We are seeing the transition. It is not a one-for-one transition, though. So if you have 10 people who were addicted to prescription drugs, they're now 10 people on heroin. We're still, the rates of heroin abuse are still relatively low, but we are seeing that transition. And ONDCP and the Centers for Disease Control are closely monitoring this. We still believe strongly that you need to work on prevention to keep people from becoming addicted to prescription drugs in order to avoid that transition to heroin. But if we get prescription drug users into treatment before their tolerance escalates to the point where they want heroin, then injecting might be avoided. There's also the economics of if you cut off the supply of prescription drugs, heroin is cheaper than keeping that supply of prescription drugs going. So it's a trend we're seeing around the country that is very disconcerting. It also means that we have higher rates of overdose due to heroin because some of the people who are now using heroin are heroin naive and their tolerance is not as high, and so they're overdosing. So that leads us to overdose prevention and education. The National Drug Control Strategy supports a comprehensive overdose effort, more extensive public education campaigns about overdose, how to recognize the signs of overdose. We're working with the American Society of Anesthesiologists to distribute cards on how to recognize the signs of overdose, because we were looking for, if someone has a heart attack, you expect to, there's been a great effort to educate people about that and to and how to administer CPR to someone. So in some communities, this is very important that individuals understand how to recognize the signs of overdose. And we're also expanding training and availability of emergency interventions such as naloxone for first responders. This is something that I know Kentucky is working on significantly. Naloxone is an opioid overdose reversal. It's been used in many emergency medical EMTs have been carrying this for years. Some police departments around the country, it is a prescription. So some police departments around the country are carrying this now. One good example, and I wish, yeah. So one good example has been in Quincy, Mass, where the police department has been carrying naloxone for a couple of years now, and it has significantly reduced overdose death rates in that city. And the police department itself has taken this on. The head of their narcotics division has been very active on the issue and is happy to help. I think he had a conversation with folks in Kentucky about how to expand this to other parts of the country. In Massachusetts they have an agreement with their state public health department, which allows the police department to carry this prescription for naloxone, and it's really saving lives and making a big difference. They're also doing this in New Mexico and in a couple of places around the country. So opioid addiction is a very, I've talked to a lot of treatment providers. I'm hopeful there are additional treatment providers in the room today who can talk about this. Opioid addiction is particularly difficult to treat. And the success and the recovery period for individuals who have an opioid addiction increases with medication-assisted therapies. That is something so buprenorphine, Suboxone, methadone, Vivitrol, those are things that it's a doctor-patient conversation about how long that person should be on it in order to sustain their recovery. Could be 6 months, might be enough. In other cases, it might be a couple of years. So making sure that medication-assisted treatment is available to people and that it is not artificially cut off. In a couple states, they've talked about you can only be on methadone for a year or 6 months, and then you're cut off. In Maine, we saw that, and it's increased the rates of overdose because people are going back on using prescription drugs or abusing prescription drugs because they have not been able to sustain their recovery. So expanding treatment options availability is a critical part of our plan as well. And then the Food and Drug Administration recently came out with another part of our plan is making sure that there are abuse deterrent formulations available. FDA recently also changed the labeling. This was something that was long waited for. It sounds arcane and that it won't make a difference, but we are very hopeful that it will. Their safety labeling changes will apply to opioids, extended release, long-acting opioids, and they'll say that it's only should be for management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. so for which alternative treatment options are inadequate. So that shouldn't be the first thing you reach for as a prescriber. And so the Food and Drug Administration, by putting this out last month, we're hopeful that it will change prescribing patterns. So it starts that supply chain piece. We'll start by decreasing the amount of prescription drugs that are just out there that can be diverted. And also, they have some, FDA will ensure access to these painkillers, make sure that they're available for people who really need them while reducing the risks of abuse and overdose deaths. So there are many opportunities for state leadership. I wanted to mention that we are working very closely with the Association of State, Territorial, and Health Organizations, ASHTO, on this issue. They have a goal, so it's basically the state health authorities. They have a goal of reducing overdose deaths by 2015 by 15%. We're also working very closely with the National Governors Association. They have regional plans that are being put together by the governors and the health departments in those states. And so we're trying to mesh all of these efforts so that we're all operating on the same page towards the same goal and building on these 4 pillars. There's many opportunities for states to lead on this. I was disheartened, I have to say, by, we saw last year a reduction for the first time in 10 years in initial past month non-medical use of prescription drugs. That gain, we lost it this year. I don't know why, but we did. But it looks like the 18 to 25-year-olds ticked up some this year. So we're doing pretty well with 12 to 17-year-olds. We're doing pretty well with 26, pretty well with people over the age of 26. But that 18 to 25-year-old age group, we're still having a problem with their initiating use of prescription drugs. Now think about that, 18 to 25-year-olds, that's a long lifetime of chronic substance use if they are beginning now. So we have to focus, and we are focusing on that age group. That's where the dentists come in, are a very important part of this puzzle, because many people in that age group, if they're getting their prescription, they're getting their first taste of opioids from the dentist when they get their wisdom teeth pulled. So the dentists are fortunately working with us to make sure they're getting the word out to their patients about and making sure they're not prescribing 60-day, 90-day supply of a painkiller for something that should go away in 2 days. It's not chronic. But that 18 to 25-year-old age group is a sticking point right now that we're working very hard on. Your states should have similar data about where the sticking point is and where your target age group is. So with that, I will conclude, and I'm happy to take any questions that folks might have.
All right, I'll buy it.
Thanks.
Mr. Buck, you were talking about doctors being highly trained and in their field. Do you all have any data on how much training physician prescribers get in both the treatment of acute and chronic pain, as well as recognition of addictive disease in their regular medical school curriculum and through residency? Very little. Veterinarians get more training in pain than the average medical student. In substance use disorders, they get none. So what we have done is we've tried to put it on the exam, the board, so that will drive the curriculum. And it is, substance use disorders, I think that a lot of folks in the medical community, I just spoke with the American Psychiatric Association last week and urged them to get involved in this debate because on drug use generally. Because for the most part, the medical community is pretty silent about this. This is a law enforcement thing. It's not my problem. And I've had people, doctors say it's not my problem if people misuse. Might not be. Might be that person has a predisposition. But it means that we do have an obligation to treat that individual once they develop a disease. We wouldn't turn someone away if they had diabetes. We shouldn't turn them away if they have a substance use disorder. Any other questions? I'm sorry?
I was alerted that there are One being that the VA does not report prescription opioids to the PDP,
Yep.
and that methadone clinics don't.
Yep, so this, the second piece is because of there is a specific law, reg, that does not require them to do that, to report, for various reasons that have gone on for several years. Now, on the VA, though, so I don't have good news on that, but on the VA piece, I do. First of all, the Veterans Administration is now allowing its doctors to look at least, the PDMP data, so there's that outflow. There is a rule that is being drafted that will allow the Veterans Administration doctors to share the VA PDMP, basically, for lack of a better word, to share that data with the state PDMP. So that should be in place in the next year so that those two data points can merge. So if you're a VA doc, you're going to be able to check the PDMP and you're going to be able to share that data. And if you're a doctor that's not in the VA system, you can see, oh, you're getting all these meds from the VA. So that'll take about a year for that to happen, but there's an interim rule out now.
Will the VA be required to report or only allowed?
They are not mandating that the state has to share data. They're going to allow that data to be shared. So there is no, I'm not sure how that would work if they could mandate that, but these are baby steps sometimes. That's a really good second step, is mandating that, which will be very challenging. Frank?
On the PDMP, while we're on that subject, I have to believe only the national PDMP are really through success and everything's on I have the same protocols in each state. And I know I talked to Director Kowski about that. At that time, there wasn't much political will. Are we moving any further to a national PDMP hospital?
Political will hasn't changed. There's still a lack thereof. So I don't see, my concern is, I don't see that happening, and if it were to happen, it'd be a big food fight on the Hill for 5 to 10 years, and I don't want to distract from what we're doing now. It's probably something that should have happened 15 years ago. It didn't, so now we have to live with what we have, because we've got, you know, this problem. So I don't see it happening now.
I'm a private practice, so I hear the stories, and my opinion is that the data we have only shows the tip of the iceberg. And I wonder, this may sound crazy, but if this Homeland Security paying attention to this, because if the benzos and opiates for this country get cut off, I think we're going to have a quarter to half of our population going into withdrawal. And when I hear stories from my fellow addictionologists from New Orleans during Katrina, that's what happened. It was really awful.
So that's why we're very, very, very careful not to say that we believe that prescription drugs should not be prescribed. I would be the last person to say that. As you know, as a lawyer, I don't really like to tell doctors what to do, and they tend not to like to hear them from me. So that is not our goal. It is a very balanced strategy, and I have to say there are people out there who are not happy with the fact that we are not saying that, who want us to say, just get rid of it entirely. And that is not responsible. Yes?
What is the LACP doing about changing behaviors and education at the community level? Are you doing some drug coalitions? Can you talk a little bit about that?
Sure. We have over 600 drug-free community coalitions around the country that are locally based. We give grants. The grants just came out for this year. We give grants to local communities to work on the issues that are, the substance use issues that are important in their community. In many cases, it's alcohol and prescription drugs. In some cases, it's alcohol and tobacco and synthetics. I know that you have many, there are many in Kentucky, there are many in Tennessee, and we have seen over time with studies on them that individuals in communities with these drug-free community coalitions have lower rates of youth drug use. So they are, the nice thing about them is we're not we're not, you know, picking out the sites. They are done by, they're peer reviewed. They are in communities of need, and the communities themselves decide what's important, what's significant in the substance use world for them. So they're very successful. You know, there's never enough of them. We want to expand them around the country. They're in 49 states. I think there's only one state that doesn't have them. They're not in every city in the country, and they should be. They're not as spread out as they should be, but they are a good resource and a good tool for local communities. Thank you. Well, the diversion, the diversion of Suboxone, I know, is of great concern to law enforcement, and we are working with law enforcement to make sure that the rules are followed. The rules around those drugs and around the distribution of those drugs is very, very tightly controlled. I understand that there are anecdotal reports about Suboxone diversion, and it's something that, you know, I know that you all see. Suboxone doesn't make you high. It preserves it. Why are people, the thing that we need to figure out is why, where is it coming from, what's the source, where is it being distributed, and why is it being distributed? So that's a diversion issue that, you know, law enforcement has to work on. It doesn't mean, however, that it doesn't work. It doesn't mean that medication-assisted treatment isn't important. So it's a concern that we need to get a handle on. If there's diversion going on, let's get a handle on it, but it doesn't mean you get rid of it entirely, which is a concern that, you know, if you say, well, there's diversion of this, you need to get rid of it. It's just like OxyContin. OxyContin might be useful for the treatment of long-term pain. Doesn't mean you throw it out. Doesn't mean you get rid of it. Suboxone is important for the treatment of prescription drug abuse. Doesn't mean you get rid of it entirely. It means you have to look at what's the problem here and how do we stop the diversion.
Suboxone has the naltrexone in it, so you don't get a buzz or a high from it. What we've found clinically is that people use it as a gap. So for instance, if I'm addicted to 80 milligrams a day, it's hard for me to get 80 milligrams every day, and so I will eventually go into withdrawal. I can buy an 80 milligram Suboxone strip or tablet and then use that to quell my withdrawal. That's going to cost me less than maybe $20 instead of $80 or $100. And then when I can get more money, I'll go back on the narcotic. So that's how it's really used. That's what we found.
Right. Right. Yeah. I mean, we're seeing that anecdotally around the country, that it's basically, and in some cases, dealers are giving it to their people to manage their high.
Just anecdotally to address that, we're also hearing some that part of the issue with Suboxone diversion is actually individuals self-medicating. So actually not using it for an addictive purpose, but due to the limited availability of doctors through the laboring system. So, you know, we're having issues with finding doctors who are willing to become Suboxone providers because it's not fiscally, there's no incentive for them to do it due to the waiver process that they have to go through.
Right.
So we're hearing that part of the diversion issue is actually individuals who are trying to self-medicate, want to use Suboxone, but just don't have access.
Yeah, I mean, the access to medication-assisted treatment around the country is a problem. Access to medication-assisted treatment that provides counseling as well as the medication, because it can't just be, here's your medication, go away. It has to be medication and treatment combined, and that's important. Did you have a question?
Okay, quick question. This may seem very ignorant. I treated patients with buprenorphine and naloxone combinations and so forth, and I agree with these anecdotal reports. Probably 30% of the patients were using it to treat their addiction on their own. They couldn't find a provider. But you say that the diversion is of great concern to law enforcement. Everything I know about buprenorphine, naloxone in particular, is people don't die of overdose. Most of them that I've come in contact with are using it to bridge to stay away from withdrawal. I'm not clear why it is of such great concern when it doesn't actually cause harm per se.
So this is why this is a great meeting today, because I want you to talk to them. Because we hear from folks, we hear this side, you know, we are conveners in the Office of National Drug Control Policy, and we hear from doctors saying they're self-treating, you know, it's a bridge, and then we hear from law enforcement saying, and I have not been to one of these conferences where law enforcement doesn't bring this up, and we hear it all the time. Diversion, diversion, diversion. And that's the, you know, that's law enforcement's job. So let's talk about this. Let's get...
The name diversion is the bad thing. You're not worried, I mean, because again, some things that are diverted, like Lortab, Percocet, oxycodone, people die from.
Well, diversion is a specific legal issue, you know, so I think in your breakouts, please talk to one another. You should have a law enforcement doctor discussion. I would encourage that, medical community discussion. Time for one more question?
Is there any rule of thumb to have the methadone clinics have to check the PMP before they continue the patient? Or if we can't find out, they make sure they're not also getting prescriptions?
So there are many discussions between treatment providers and PDMPs. It depends on the state law and who can have access. In some states, treatment providers who are not, whoops, sorry, they may not be able to have access. So it just depends on the state. But there's lots of discussion about that. All right. Thank you so much.